So just as a matter of introduction, like I put here three perspectives on studying our high-performing organization and system, and I will use probably interchangeably system and organization in this introduction. And the first ideal type, let's put that way, is taking a very macro perspective and looking at broad feature of its system. So probably it came to your mind study from OCDE who try to look at broad parameter of its system and try to assess their impact on performance, like we got in their 2011 report. And very often this type of study focus on financing and manpower and regulation. So manpower, a lot in terms of provider mix, supply of different profession in the system, and so on. So as you may expect, this type of study is on one side very important. It may help to identify broad parameter, but it is based on I guess we say in meters now. It is based on a 13,000 meters view of health system. It does not help much when you try to understand why a given organization or a given region in a system perform more than other. So it doesn't deal with internal variation in performance in the system. So I don't downplay the scholarship and the learning from this study. I just say that when you try to get closer to practice and process and mode of organizing that makes a difference, it may be short of insight for that side. If we go to the other extreme, and this morning PG referred to the Boehmer paper in the New England Journal of Medicine, a more macro perspective, that focus on program and intervention to achieve highest quality or safety or better outcome. And very often here the focus is on specific program around specific design, and we focus more on macro clinical system. And again, of course, it brings important insight, but it may be limited when it is time to understand how context generate this kind of performance clinically. Or saying differently, micro clinical system do not operate independently of their broader organizational or policy context. And then a meso perspective, which we use meso to identify the organizational machine that deliver care. And of course, you have provider in these organizational machine. And the focus here is on strategies and investment in organizational and I guess system resources to create and sustain high-performing system. So the focus here is really on the strategic investment and the capacity that develop within a system for improvement. And of course, these three perspectives are not mutually exclusive. And we will see this with some example when it is time to look at why a system or an organization perform. We will probably find element of answer at these three levels. Having said this, the organizational perspective or the meso level becomes very attractive recently because it was probably neglected for a while. We have policy study at a very macro level and very micro study of good intervention, and maybe the middle was less developed. And the And why it become interesting too, it's probably a matter of change dynamic in system, and this would be a kind of caricature. You can wait a lot before changing the modes of paying physician, like people discuss, like Zeke Emmanuel discussed, switching from fee services to something else. And you may be at risk also to probably hope too much, like seeing in this a magic stick. And the growing interest for looking at the organizational context is based on this very simple hypothesis that you need an enabling context to benefit from the other changes. So that's why the organizational dimension become, I guess, a matter of interest. So next slide, I will just briefly talk about some of the work that we did with Ross Baker. So I will first mention that this small report is a kind of ramification or development from his 2008 book, Quality by Design. And as you remember, this book, they look at high-performing system, I guess 7 or 8 system going from Birmingham East in UK to Young Shipping in Sweden, to Intermountain VHA, to Trillium in Mississauga near Toronto. And the idea behind this 2008 book was to describe the journey of some regional system or organization that have seems to improve through time. Not only systems that have good performance, but to look at their journey and trying to describe what they did without, and this is not negative, without necessarily developing a lot the theory of improvement, but looking at their practice process, their ingredient, to try to have a clearer idea of how organization in systems that have always limitation in terms of resources, constraint, achieve improvement through time and sustain it. It does not deal, however, with the problem of scaling up or spreading across a system the pathway they cover in the period of study. So in 2011, the Canadian Foundation asked us to sort of, let's put that way, update, not because the book was updated, but to look at some cases and doing some update about what we can learn about high-performing system. So it was a small project. I won't talk about the budget, but there is a big difference with the resources that Glenn did from the European Commission. But we look at 3 systems, and one is an update of the 2008 cases, Intermountain Healthcare, headquarter in Utah, in US, and I will not go in detail. It's just that Intermountain is very well known to have systematized attention to best practice and the use of guidelines across the system, and having improved their clinical outcome and reduced their costs by approaching this in a very systematic way. But they achieve this through time. This is one of the message. You don't think about this Monday and Wednesday the job is done. And another small lesson to retain from Intermountain is that they push a lot for guidelines and best practice, but they advise their clinician and their leader that please I want some people that will not comply to guidelines and best practice because I want clinical judgment in the system. So on one side they push, but they try to value also a clinical judgment. The other cases, which was also in the 2008 book, Quality by Design, is young shipping in Sweden. It's about 130 kilometers from Gothenburg, a semi-rural area. And again, for today, just one element. They really switched their strategy through time toward improvement, and they use as a representation of their strategy a very simple technology, which was a virtual patient. They called the virtual patient Esther. I don't remember all the details, but a woman around 80 years old with multiple chronic disease and so on at home. And they say, if we want to offer the best to this virtual patient, what we will do. And they really shift gear and focus the system toward quality improvement through time. And again, outcome seems to follow. And I don't remember the exact detail about cost, but certainly they manage within their financial boundary. And this is a nice case because it's in a system that has a constraint and regulation similar to our system, but in one region or district, they make substantially different than the others. So that's why sometimes we got very interested on this degree of freedom that organization can have to improve. And then the new one is South Central Foundation in Alaska. So Anchorage, Alaska. It's not in Bermuda. It's quite cold. Widespread population, First Nation population, 45,000 about people in a widespread territory. And for people who are familiar with LTCU for First Nation, they were comparable to what we know in Canada, so a very negative situation in terms of health status and well-being of the population. And just to make the story short, you have this young woman who came from this community, went out, studied, get an MBA, become the CEO, and the first day said, the system just not work. We don't deliver something that people need, and we should stop. We better to close it if we don't change it. And again, they change it significantly. It's also in the American context. They use the label consumer owner system, but the way they bring on board the population, define priority, change the way they use professional, and just as an example, they have a nice matrix. I don't put this on the slide, where they say, more you're in a low acuity situation clinically, more in quotation, it's the patient who is in control of the outcome in its social environment. And they really use this kind of matrix to make the best out of their resources. Again, it's not ID system. It's just system that are totally diverse in size, history, location, as you see. But they have all, and I will close on this after, they have all used some quality improvement methods more systematically. And for the one who is from Quebec, you know that lean is very popular, but I will say it's lean with clear clinical vision. And that's the fundamental of it. And then they also pay a lot of attention of using professional resources and provider mix in a much more efficient way than we usually do. So just to close on this, we sort of identify 10 things by comparing these three systems, building up on the 2008 study and some literature. And I will not cover all them, but one of the, let's look at these themes as some regularity in our observation around these systems. One is they really focus on quality improvement in the broadest sense of the term. It becomes a kind of obsession, and then preoccupation with cost follow, but it's not the main driver. Just the second item in the first column, and it's framed here in very managerial term, but it's really the idea that they all focus on leadership capacity development, not just at the managerial level, but at the clinical level. So clinical leadership for improvement become a central preoccupation, even in the small system South Central Foundation, where they dedicate a lot of their small resources to bring him up, these person. And this is totally in line with what, in quotation, we know in our organization about collective and distributive leadership in this kind of organization. I won't detail all this, but they certainly take a switch toward, call it primary care, community-based resources, but they really refocus part of their allocation of resources on this as the main engine to make the system shift toward improvement for their population. And I won't detail all this. So the challenge is how to implement and sustain this kind of attribute in high-performing organization and system. And I would add on the slide how to scale up and disseminate and adapt, which is an issue. So to make the story short, you can get a lot passionate in this study, but ended your research process with various elements where you have a kind of shopping list. You know, good system or high-performing system do ABC, but then the issue is trying to look behind to understand what makes this feature happen. So I will finish with 3 questions that we may come back on the panel. So to look behind the, and I'm not saying negatively, but the shopping list of attribute, there is first one hypothesis, which is the complementary hypothesis, is to bring about this change, you can probably not focus on just one element. You have to probably focus on multiple elements, because if you just improve your information system and don't develop effective teamwork and so on, it may not deliver. So I make it short because time's run. The second hypothesis, and I just framed this term this morning, so the contextual hypothesis is that the strategy will vary from system to system from where you start, because it will depend about all sorts of factors, political, historical, economic, organizational, and so on. And the last hypothesis is, from this study, very often we get stories that look so nice that it's very, very exciting and ideal, but the real life may be less fairy tale than this. So the third hypothesis is nonlinear and multidimensional hypothesis. Improvement or change is not a discrete event. It is a process that proceeds gradually and with unexpected evolution. So I take longer time because Ross is not there and I still not see the third one. So I have to do some improvisation. Thank you for your patience. Now, Glenn Roberts.